So artificial intelligence and other levels of technology are really key in promoting cardiovascular medicine and improving access to care. One of the key things we talk about is these technologies should be relevant to us because some of them have been studied in other communities and are usually not easy just to bring them in and apply to. We need to be culturally sensitive, gender sensitive, age sensitive. So we usually have the honors to digest and see what kind of technologies and artificial intelligence mechanisms we can be able to apply. But and of course, one of the other issues is the digital health, not just to the populations but also to healthcare workforce, because adoption has really been a big challenge. Many clinicians are used to the old model of working out medical provision, and they need to inculcate these new technologies. The involvement or incorporation of these technologies into existing healthcare systems can also be quite robust, where a certain hospital or institution already has its mechanism of how to take care of patients. When you add on these new systems that are not necessarily integrated, it's like double work for the healthcare provider. So we're encouraging healthcare facilities to see how they can integrate these systems into their existing healthcare workflows so that it can be very easy to use. For example, management of hypertension, we've had various softwares that are now being used where patients can remotely be monitoring their blood pressure, feed it in an app, and a clinician sitting hundreds of kilometers away can actually monitor and see my patient is doing well, is well controlled or is not controlled, and just be able to give feedback to the patient. Same thing for management of chest pain, for example. Remote doctors in remote areas can be able to do things like ECG and be able to transmit them to doctors in the tertiary hospitals who have the knowledge to interpret and tell this patient is okay, you can take your time and treat them, or this is an emergency, you need to refer them immediately to advanced healthcare services. So technology is actually there, we are using it, and it's really helping a lot. So specialists are not enough, and the data for, I will tell you, like for the entire continent, we have a ratio of 1 to about 100, one cardiologist to 100,000 patients. This is way below the recommended rates or what we could compare with the Western world. But we probably would be looking at who else can provide cardiovascular care to our patients if we don't have those cardiologists. And this is an area where we've come in with what has been recommended as task shifting and task sharing. We can create the capacity and competence in individuals who are trained in lesser areas than cardiology, but they can have the technical know-how and the competence to treat some of the cardiovascular diseases, and only refer patients who are extremely complicated to the specialists, because these are only found in the urban areas, very few centers. So that model is working pretty well. Treatment, for example, of diseases like hypertension has been scaled down to the lowest level. What the community health workers do is to screen, and if they identify anybody with elevated blood pressure, they refer to the level 2 or 3 hospitals. The clinicians there can actually be able to treat the diseases. The medicines are available.
At primary healthcare level, that's at his dispensary and health center level, we've empowered the healthcare worker there to be able to manage uncomplicated cases of, for example, hypertension. They're able to diagnose, and they're also able to give the much needed treatment. And then they're also supposed to have a high index of suspicion with for someone who has another heart condition that requires referral to the next level of system. So first, it's ensuring that the primary healthcare level is very responsive, able to detect. But we know the nature of the of cardiovascular diseases. They are very unique. Some of them are very complicated and can't be handled at that lower level. So there is need for specialization, and we are indeed trying to employ some measures. And one of them is task shifting, where we have people getting either an echo done. Long time it used to be a very specialized skill, but right now we are training, for example, the clinical officers to be able to do echoes. And then in the interpretation, they might be held by a cardiologist or a physician. So we are bringing those very high specialization services a bit lower by capacity building of the majority of the healthcare workers we have. Like CEOs are very much more when you compare them to cardiologists. Another thing is we know this is a lifelong disease. You have to keep on taking medication. And for that reason, we reformed the health financing landscape through the Social Health Authority by introduction of the three funds, the Primary Healthcare Fund and SHIV. Maybe if I can narrow down to SHIV, which is the contributory fund. So we are able to now take care of our patients' medical expenses at a higher reimbursement rate than what used to be there in NHIF. We are doing this so that we don't have the healthcare workers, the patients, having catastrophic expenditure. As I said before, this is a lifelong disease and they need to be on medication and also constant follow-up. Also, quite a number of these cardiovascular diseases might end up in surgical care, and there is an improvement in the surgical care package under SHIF.